Welcome. Today's lecture is DKA and HHS. Hopefully this lecture is as sweet as these patients. That was my dad joke for the day. I will not do another one. Thank you. So, DKA, diabetic ketoacidosis and hyperosmolar hyperglycemic state. DKA and HHS are not just a high glucose. They're volume depletion, they're electrolyte derangements, and they're a trigger, which means what's causing this until proven otherwise. The boards test the sequence of fluids first, potassium before the insulin, as well as insulin until that gap closes. In children, you're scared shitless because if they have mental status changes, you're concerned for cerebral edema until proven otherwise. All right, so here's the objectives. First, we're covering DKA and HHS. Congratulations. We got to go over the diagnostic criteria. Secondarily, identify and treat the precipitating factors that cause them to either be in DKA or HHS. Third, execute the ED treatment sequence in the correct order, emphasis on correct, and ordered, and correctly ordered, and ordered correctly. Fourth, know the potassium thresholds that change insulin timing. Fifth, recognize and manage cerebral edema in pediatric DKA. Sixth, recognize euglycemic DKA. These are typically patients that are taking SGLT2 inhibitors. So they have a lot of urinary tract infections, or they have chronic kidney disease and the nephrologists like to put them on it because it's renal protective. And seventh, avoid the classic board traps. The ED mindset for hyperglycemic emergencies is sequence over diagnosis. The label of DKA or HHS is less important than asking three questions. First, what's the dangerous physiology right now, this second? It's the shock, it's the acidosis, it's the potassium. It could also be a mental status change. Second, what trigger is driving this presentation? Is it infection, missed insulin, myocardial infarction? Are they pregnant? Are they drunk? Or is this pancreatitis? Third, what is the next best step that changes outcome? Fluids, potassium, insulin, or trigger therapy? The right diagnosis with the wrong sequence kills these patients. DKA as well as HHS exist on a spectrum, but the boards test the core distinctions between. DKA is absolute insulin deficiency. The patient has hyperglycemia, ketosis, as well as an anion gap metabolic acidosis. HHS is relative insulin deficiency. The patient has severe hyperglycemia, profound hyperosmolality, minimal ketosis, as well as an altered mental status without significant acidosis. DKA is more common in type 1 diabetes, however, it is not excluded in type 2. HHS is more common in type 2 diabetic patients, elderly patients, and those with limited water access. Mixed presentations are highly common. The board concept is that both require fluids first, both require electrolyte attention, and both require a trigger search for what caused it. There are three major diagnostic criteria for diagnosing somebody with DKA. First, you'll want to look at the sugar. What is it? It's typically, in these patients, greater than 250 milligrams per deciliter. But remember, euglycemic DKA patients do exist. They're not just unicorns. And these patients typically have a history of taking SGLT2 inhibitors. They're pregnant. They plan to be pregnant, kidding, or prolonged starvation. Secondarily, ketosis. This is demonstrated by elevated serum hydroxybutyrate level or just a moderate to large urine ketone. Beta-hydroxybutyrate is the dominant ketoacidosis in DKA and is more common than urine ketones seen. Third, anion gap metabolic acidosis. There's a pH less than 7.03 for that diagnosis. There's a bicarb less than 18 milliequivalents per liter and an anion gap greater than 12. Severity classification utilizes both pH as well as mental status to grade from mild to moderate and lastly severe DKA presentation. Diagnostic criteria for HHS include severe hyperglycemia, typically greater than 600 milligrams per deciliter, profound hypoosmolality with effective serum osmolality greater than 320 millimoles per kilogram, with minimal ketosis present. There's going to be a pH greater than 7.3 and a bicarb greater than 18. Altered mental status will range in these patients from mild confusion all the way to full-blown coma. HHS develops over days to weeks, not hours like in DKA. The patient is profoundly volume depleted, often 8 to 12 liters so. The trigger is often infection, or it could be a missed medication dose. All right, so now you're shitting yourself. You got this suspected DKA versus HHS patient. What the hell do I do? So the first thing is you got to be structured as well as time sensitive. And I know I'm talking to ED folks, so good luck. But you want to get that finger stick glucose immediately. Hopefully the triage nurse has already got one done for you. You want to get a chemistry panel on them to assess for electrolyte derangements, look at their bicarb level, look at that anion gap in their kidney function, order that beta-hydroxybutyrate, order those urine ketones, see if their piss tastes like sweets,
get a venous and arterial blood gas for pH and partial pressure of carbon dioxide, assess serum osmolality when HHS is suspected, perform that EKG to evaluate for potassium effects and to rule out ischemia, get your CBC, get your lipase if there's belly pain, pregnancy test in the age appropriate, order the blood cultures and chest imaging when you suspect infection. Hemoglobin A1C is helpful, but no one in the ED in their right mind really orders one.
So the anion gap drives DKA recognition as well as resolution. Anion gap is calculated as sodium minus the sum of chloride plus bicarbonate. A normal gap is 8 to 12. In DKA, the gap is typically 15 and higher. You want to order that beta hydroxybutyrate because it's the dominant keto acid early in DKA and shifts the acetoacetate during the treatment. Urine ketone strips primarily detect acetoacetate, so urine ketones may paradoxically appear to worsen during successful treatment. Use serum beta hydroxybutyrate to track for resolution with values below 0.6 millimoles per liter indicating resolution, but do not chase the urine ketones. Always look for the trigger. The classic mnemonic is the 5 I's. Infection, a UTI, pneumonia, gastroenteritis, skin and soft tissue infection. Could be infarction, so an acute MI, especially in the elderly. Insulin deficiency, so did they miss a dose? Are they using expired insulin? Is there a pump failure? Intoxication, so could they be drunk? Could they be high? Could they be on stimulants? Inflammation, are they suffering from pancreatitis or cholecystitis? Add to that pregnancy, surgery, trauma, as well as steroid use, and a new diagnosis of diabetes. The board concept is that treating the metabolic derangement without finding the trigger is incomplete care. The ED DKA treatment sequence is fixed and tested. So the first thing is fluids. Start these patients on isotonic crystalloid resuscitation immediately. Second, potassium. Check the level and decide whether to give potassium or to hold insulin. Third, insulin. Start the drip only after the potassium decision is made. Fourth, dextrose. Add when glucose drops below 200 milligrams per deciliter to continuous insulin until the gap closes. Fifth, close the gap, not the glucose. Continue insulin until the anion gap normalizes, then transition them to subcutaneous insulin with overlap. Sixth, bicarbonate only for the severely acidotic patients with a pH of 6.9 or less. Seventh, treat the trigger. What's causing them to be in DKA or HHS? The board principle is that this sequence is unforgiving. If you skip a step and the patient deteriorates, that's bad. Fluid resuscitation is the first ED action and the most important. Start with isotonic crystalloid, normal saline or LR, at 15 to 20 milliliters per kilogram in the first hour. Typically 1 to 1.5 liters in the average adult. Reassess the volume status. This consists of the blood pressure, their urinary output, and corrected sodium. Subsequent fluids are guided by corrected sodium. If the corrected sodium is normal or elevated, switch to half normal saline, which is the 0.45 saline, at 250 to 500 milliliters per hour. If corrected sodium is low, continue normal saline. When glucose drops below 200, add the dextrose. The board concept is that the fluids alone substantially lowers glucose and improves the perfusion, even before the insulin begins. Potassium management is the highest yield board concept in DKA. Despite total body potassium stores being depleted, the initial serum potassium can be high, normal, or low due to insulin deficiency and acidosis driving potassium out of the cells. Once insulin is given, potassium shifts back intracellularly and the levels drop quickly. The rule is simple. If serum potassium is less than 3.3, do not give the dang insulin. Replace the potassium, first with 20 to 40 milliequivalents per liter in fluids until the potassium is above the 3.3 threshold. If potassium is in the range of 3.3 to 5.3, add 20 to 40 milliequivalents of potassium per liter of fluid and start the insulin. If potassium is above 5.3, you don't need to give the potassium right away. You just recheck it in 2 hours. The board trap is starting insulin in the hypokalemic patient and precipitating cardiac arrest. Insulin is started only after the potassium decision is made. The standard regimen is continuous IV infusion of regular insulin at 0.1 units per kilogram per hour. A bolus of 0.1 units per kilogram IV push is optional, but it's not required. A sub-Q insulin, such as Lispro, at 0.3 units per kilogram, then 0.1 units per kilogram every hour, is an alternative for mild to moderate DKA. The infusion rate is adjusted based upon the glucose trajectory, but the goal is closure of the gap, not normalization of the sugar. The board concept is this, all right? So red flags or big sirens, however you want to focus in on it. It's the insulin that's the engine that closes the gap. it must be continued until the gap closes by 2 serial gap closures, even if the glucose normalizes earlier. The glucose target during DKA treatment is a controlled descent. The goal is a fall of 50 to 75 milligrams per deciliter per hour. Faster drops increase cerebral edema risk, especially in children, and shift fluid into cells. When glucose drops below 200 milligrams per deciliter, add the dextrose-containing fluids. This is typically dextrose 5% and half normal saline, or dextrose 10% if needed. The insulin drip continues at the same or slightly reduced rate. The board concept is that the insulin drip is for the gap, not the glucose. Once glucose is below 200, you keep the insulin going by feeding glucose alongside it. Resolution of DKA is defined by closure of the anion gap, not by normalization of glucose. Criteria for resolution include anion gap less than 12, bicarbonate greater than 18, a pH greater than 7.3, and the ability to tolerate PO. At that point, transition the patient to sub-Q insulin. The transition requires overlap, however. Give the first sub-Q insulin dose at least 1 to 2 hours before stopping the drip. Stopping the drip prematurely leads to rebound DKA with just a couple hours. The board trap is stopping insulin when glucose normalizes, but the gap is still wide open. Bicarbonate is not routine in DKA. It does not improve outcomes in most cases, and it actually may worsen paradoxical CSF acidosis, hypokalemia, and cerebral edema. Consider bicarbonate only for severe acidemia with pH less than 6.9 or in cases of refractory hyperkalemia with cardiac arrhythmia. When given, the dose is 100 milliequivalents of sodium bicarb in 400 milliliters of sterile water, infused over 2 hours, with 20 milliequivalents of potassium chloride added if no contraindication is present. The board concept is restraint. Bicarbonate is the wrong answer in most DKA cases. HHS management differs from DKA in important ways. The volume deficit is larger, often 8 to 12 liters in adults. Start with isotonic crystalloid at 15 to 20 milliliters per kilogram per hour. The fluid replacement is the dominant therapy. Insulin is typically lower dose, starting at 0.05 units per kilogram per hour because the dehydrated patient is more sensitive. Glucose drops should be slow, less than 50 to 70 milligrams per deciliter per hour to prevent cerebral fluid shifts. Mental status improves with fluid and glucose correction, but slowly. Triggers in HHS are often serious: infection, MI, stroke, or new diabetes. The board concept is that HHS is a fluid problem with an insulin component, not the reverse. Pediatric DKA management is conservative by nature because of their cerebral edema risk. Initial fluid bolus is 10 to 20 milliliters per kilogram of isotonic crystalloid over 1 to 2 hours, not the aggressive boluses used in adults. Subsequent fluids are calculated to replace the deficit over 24 to 48 hours very slowly. Insulin is started at 0.1 units per kilogram per hour, but never with a bolus in children. Recent evidence from this PCARN fluid trial shows that the rate of fluid administration does not directly cause cerebral edema, but cautious management remains standard. Avoid rapid sodium changes. The board concept is that pediatric DKA is slower and more cautious than adult DKA. Cerebral edema is the leading cause of death in pediatric DKA, with mortality around 20 to 25%. Risk factors include young age, new-onset diabetes, severe acidosis at presentation, a low partial pressure of carbon dioxide, a high BUN, and the use of bicarbonate. Warning signs include headache, recurrence of vomiting, lethargy, fluctuating mental status, age-inappropriate incontinence, and the Cushing response, which is hypertension and bradycardia. Treatment is immediate mannitol 0.5 to 1 gram per kilogram IV over 20 minutes, or 3% hypertonic saline, 5 milliliters per kilogram over 30 minutes. Do not wait for the CT scan to treat this patient. Elevate the head of the bed 30 degrees, intubate if needed, and contact pediatric ICU. The board trap is delaying treatment for imaging. Euglycemic DKA is a critical board concept. The patient has ketosis and anion gap acidosis, but glucose is normal or only mildly elevated, often less than 200 milligrams per deciliter. The classic setting is a patient who utilizes an SGLT2 inhibitor, they're pregnant, they've had prolonged starvation, or they're a chronic alcoholic. Treatment is the same. Fluids, electrolyte management, insulin infusion at 0.1 units per kilogram per hour, and dextrose coverage from the start because glucose is already low. Hold the SGLT2 inhibitor. That's paramount. The board trap is missing DKA because the glucose number does not catch the diagnosis. Disposition is determined by the severity of their presentation, response to treatment, and the trigger. ICU admission is appropriate for severe DKA patients defined by a pH less than 7.0, a bicarb less than 10, with altered mental status, hemodynamic instability, or comorbid critical illness. Step-down or telemetry admission is appropriate for moderate DKA as well as stable HHS. DKA and pediatrics generally require pediatric ICU. Mild DKA in a stable patient with resolved gap and tolerating oral intake may be considered for floor admission or rarely observation pathway with close endocrinology follow-up. The board principle is that the disposition is driven by physiology as well as the trigger, not by the lab cutoff alone. The board traps are predictable. Starting insulin before checking potassium and precipitating cardiac arrest. Stopping insulin when glucose normalizes but the gap is still open, leading to rebound. Using urine ketones to track resolution instead of serum hydroxybutyrate or the gap. Missing euglycemic DKA in an SGLT2 user. Giving bicarbonate routinely. Delaying cerebral edema treatment for CT in pediatric DKA. Aggressive fluid resuscitation in HHS without monitoring corrected sodium, and failing to look for and treat the precipitating trigger. Case number 1. A 24-year-old with type 1 diabetes presents with 3 days of vomiting and abdominal pain. Their glucose level is 460, bicarbonate is 8, anion gap is 24, the pH is 7.15, serum potassium is 3.0. So the correct next step should be what? Yes, it should be holding the insulin, give isotonic fluids with 40 milliequivalents of potassium chloride per liter, and recheck potassium in about 1 to 2 hours. Once potassium is above that 3.3 threshold, then you can begin starting insulin at 0.1 units per kilogram per hour. The board trap is starting insulin in a hypokalemic patient and causing a cardiac arrest. Case number dose. An 82-year-old nursing home resident presents with ultramental status. Glucose is 940. Serum sodium is 156. Bicarbonate is 22. pH is 7.38. Effective osmolality is 350 milliosmoles per kilogram, just 350. Beta-hydroxybutyrate is not significantly elevated in this patient. So, this patient is in HHS. You want to begin fluid resuscitation with 1.5 liters of normal saline over the first hour. Look hard for the trigger. Urinalysis, chest x-ray, blood and urine cultures, troponin, and the EKG. Insulin at 0.05 units per kilogram per hour after the potassium decision. Slow the glucose descent. Pediatric mortality is the wrong concern here. The risk is in the elderly, fluid resuscitation mismanagement, and the missed trigger. Case 3. A 10-year-old with new-onset diabetes is 6 hours into a DKA treatment. He has been improving. Glucose is now 200. The anion gap is closed from 28 to 14, but over the last 30 minutes he became lethargic with a headache. His blood pressure has climbed from 100 to 140 over 90, and his heart rate dropped from the 120s into the 70s. This is cerebral edema until proven otherwise. We want to treat immediately with mannitol 0.5 to 1 gram per kilogram IV or 3% hypertonic saline 5 milliliters per kilogram. Elevate that head of the bed 30 degrees, reduce the fluid rate, call your pediatric ICU specialist, and consider intubating this patient. Do not wait for the CT before you start treating this patient. The board trap is sending the patient to CT before the treatment begins. Question 1. A patient with DKA has a potassium of 2.9. What's the next best step? If you said, hold that freaking insulin and replace that potassium first, you ding dong, you're correct. So you want to give isotonic fluids with 20 to 40 milliequivalents of potassium chloride per liter until the potassium is above 3.3. Then you start the insulin infusion. The board trap is starting insulin in a hypokalemic patient and precipitated cardiac arrest. Question 2. A patient with DKA has glucose of 220, but the anion gap is still open at 16. What do you do? Yeah, you want to add dextrose-containing fluids and continue the insulin infusion. The insulin must continue until the gap closes, not until the glucose normalizes. The board trap is stopping insulin because the glucose looks better. Question 3. A pediatric DKA patient develops a new headache, bradycardia, and hypertension 6 hours into treatment. What's the next best step? If you said the answer is immediate treatment for cerebral edema with mannitol and hypertonic saline because I've been listening to this lecture slide for the past 30 minutes, you're correct. You don't wait for that CT scan. The board trap is performing imaging before treating a clinical diagnosis of cerebral edema. Here are the key takeaways. DKA and HHS are volume, electrolyte, and trigger problems, not just glucose problems. The ED sequence is fluids first, then potassium, then insulin with dextrose added when glucose drops below 200. Insulin continues until the anion gap closes, not until the glucose normalizes. Bicarbonate is rarely indicated. HHS requires more fluid and lower dose insulin. Pediatric DKA is conservative because cerebral edema risk. Euglycemic DKA in SGLT2 inhibitor users is real, it's not a unicorn, and can be missed if you anchor only on the glucose. Always find and treat the trigger. References for this lecture include Rosen's Emergency Medicine 10th edition, Foundations of Emergency Medicine Board Review, the American Diabetic Association Consensus, Statements on Hyperglycemic Crisis in Adults, the International Society for Pediatric and Adolescent Diabetes Guidelines for Pediatric DKA, the PCARB Fluid Trial, the Pediatric Fluid Management and case literature on SGLT2 inhibitor associated euglycemic DKA, local institution protocols for ICU admission criteria, and insulin infusion management guide site-specific decisions.